I'm going to introduce you to Richard Lowrie. He's the Honorary Clinical Senior Lecturer at the University of Glasgow, and he's going to talk about getting it right with people with a drug problem affected by homelessness. Thank you, Richard.
Thanks. Get it right, Richard, and use the right button. So, yeah, thanks very much, Arthur. 20 minutes. So, yeah, I'm Richard Lowrie. Yeah, Honorary Lecturer, but I haven't seen that title for a long while. My full-time job, salaried, is with NHS, Greater Glasgow Clyde. I'm a pharmacist, independent prescriber. And my role primarily over the last 10 or so years has been to have clinical practice as an independent prescriber, and my choice is to work with people experiencing homelessness in Glasgow. So unashamedly, most of what you're hearing now is Ouija-centric, and that's fine. I also have a research remit, so I lead research for pharmacy across Greater Glasgow Clyde, so there's a lot of stuff here which is to do with evaluation of what we have done as a result of all this learning, which is create a new service. Because I think it's well overdue that we start to drastically reorganise how we offer care to people experiencing homelessness with a problem drug, at least one problem drug use. So this is more about a wee bit of evidence to do with why we have done what we've done, and describing how the changes we've made have impacted patients. So I'm hoping that some of it is new, although there will be a lot of resonance with previous stuff that's been presented today. The question that I've got there, I'm obviously answering no to that for the majority of patients that we come across in my own experience in Glasgow. The answer is no for most patients, and I think that's why we need to change things. The service that we offer is assertive outreach, which I'm sure you know, but just to make sure, assertive outreach is where the dance begins. So you don't know people, but you go to them and you ask, how are you doing, what do you need help with? Okay, this isn't us going into a hotel like, you know, the St Enoch or the Rennie Mac or any of the other ones down the road there and going to see one person. This is us going there and saying, right, here we are, this is what we're doing, do you want a hand with it? Okay, unconditionally. The other thing I would say, just by means of intro, is that, you know, realistic medicine, I think the chimes of it throughout today's presentations, realistic medicine to me is good and makes sense, you know, in context, but for the people we've come across and that we still continue to come across, it's more about, and as you said there, Katie, a minute ago, the way you do things rather than what you do. So the relationality, again, is absolutely key. So that's missed out of the definition of realistic medicine. I'd want to put it back in for this population. Again, got it wrong, but here we go. So here we go. So yeah, I mean, the Phoenix service is one that we've started and that we offer now in Greater Glasgow and Clyde, and it's a long-winded acronym that talks about pharmacists and homelessness and prescribers. Essentially, what we do is we work with third sector, so we always go in twos. How are you doing, David? I never noticed you were there. So David, right on cue, is a worker from the Marie Trust. He's one of our colleagues, so we always go in twos. One pharmacist with a Marie Trust worker, or George is over there, the Simon community. Okay, so we always go with third sector person. And the reason for that is really simple. We go to offer people help with whatever they see is important. And for a lot of people, it's about their housing. For some, it's about their benefits. For some, it's about doing stuff during the day that's productive. Okay, so I can't do any of that, you know. And besides, I don't really have relations with these guys, whereas George and co and David and co do. So, you know, I think we've missed a trick in terms of homelessness over the years, where we need to rely on these guys who work with people and know them to engage initially. And it's with that relationship you can then do a hell of a lot more, you know, including medication-assisted treatment or whatever it is we describe as the next game in town. So what I'll cover quickly is, you know, the first wee bit of evidence will be one slide describing a guy I've known for a lot of years in Glasgow, calling him Jamesy, which is quite powerful, I think. And then I'll talk about semi-structured interviews that we've conducted with 20 Jamesies over the last 6 months, all through research, so it's quite robust. Talk about a systematic review and meta-ethnography, which is quite hard to say without your teeth in, but I've managed it for once. And then we'll talk about, you know, semi-structured interviews that actually happened as a result of drug death task force funding recently. All of which kind of say the same thing, but the point is, what do we do about it? So I'll tell you a wee bit about then, for those who prefer numbers to words, I'll tell you a wee bit about the characteristics of people that we see, people experiencing homelessness, who've had a recent overdose, because that's our target group really. Okay, the hardest to reach, the worst off in society, I would say. And then we'll go on to talk about whether you think what we're doing just now, the Phoenix service, is something radical, or whether it's actually just plain courtesy. Jamesy there used to hang about Central Station, typical. I've obviously changed some of the details so that nobody recognises who it may be. But Jamesy is a guy who surprisingly has lasted this long, fair play to him. You know, most folk in this boat would have died a long time ago. He's been homeless in Glasgow for 24 years, in and out, which is a shocking statistic on itself. Lives in unsupported accommodation, temporary accommodation, different places all the time, hunted by different gangs. Once you get to know him, you realise that's the issue. In and out of jail, goes to jail to get support and to get a wee bit of relief and to escape things. And he's barred from lots of different places, you know. No supportive relationships really, apart from ourselves, because we go to him every week. And also he's an excellent addictions worker, okay. And he's on ESA, which is a type of benefit, and he should be on 3 because of his conditions. Jamesy, typically if you go looking for people experiencing homelessness who've had overdoses, you find that most have had at least 3 in the last 6 months. At least 3, some double figures, 20, 30 overdoses in 6 months. You know, and he's got lots of different problems, lots of different health problems. Don't know, on average 10, 11 health problems when you look at things. We'll talk about that in a wee minute. All of which probably, or one of which would floor any of us, I would suggest. We complain about toothache, you know, so he's got that mixed in with everything else. Stigmatising, Kevin, was it? You asked a question there a minute ago. Stigmatising attitudes, they're as harmful to Jamesy as any of the above, and we shouldn't make any bones about that at all. And it typically he used to tell me all the time, he wants to blow himself up in George Square, you know, to take folk with him. That was his sincere wish, because the quality of life was so poor that if rated by people in mainstream like ourselves, we would say that it would be worse than death. So you can measure these things, and we've measured it, and that's what we've found. So not the best. In terms of drug use, this is again typical. Most of you will know that. On average, he uses 3 illicit substances on a regular basis, meaning daily sometimes. Street Valium, heroin and cocaine, and the heroin he injects into his groin or his groin sinus, such as the state of things. And he's irregularly prescribed with these different inhalers, you know, he's kind of dropped in and out of care, nobody following him up. Contacts with the health service, you would expect us to be all over the guy like a rash, but we're not, because the services we have don't work in that way. We've heard a lot about complexity, a lot about high threshold services. So in fact, he's not really had much support at all. And this isn't during the pandemic I'm talking about, this is recently. So this is hot off the press for this guy. So we talk about, for Jamesy, we talk about recovery capital, you know, that a lot of you guys will be aware of, which has got to do with, you know, the kind of human capital. It's got to do with the physical capital, the emotional, what else? There's cultural capital we talk about. All these things you need to be able to dig down into when you're really struggling, and you need those things to initiate and sustain recovery. I would say that your man's got pretty much none of those, and so we need to start from the very beginning with him and acknowledge that. So we interviewed 20 odd people in January time with an independent researcher from Glasgow Cali called Natalia Farmer doing that. She interviewed 20 people and asked them, why do you overdose? That's an important part of our work. We need to know what motivates people to overdose. We kind of thought we had an idea, but you're better hearing it from patients directly. And also at the same time, what helps prevent you overdosing, you know. And we looked at the transcripts, so everything was audio recorded, transcribed verbatim, analysed by 3 different people, all independent, to come to themes. Okay, he talked about the process. And those themes are really important, because they give you more weight than maybe one person. Does anybody know what the main reasons for overdose were? Anybody want to hazard a guess? Aye, but see, like, so maybe I've not asked the question, right? So it's why that person overdosed, it's not the cause of it. Like, you know, because the drugs are the cause, but it's kind of what lies behind the motivation to overdose. Depression, aye, so mental health issues, definitely. So, suicide, aye, I mean, it's an easy way for people to end it all, you know. What's that, sorry? I can't hear that, sorry. Aye, it's the accent in it. It's I want to speak as, aye. So, I'll move on then. The two main reasons for overdose, blankety blank. So, escaping the reality of re-traumatising risk factors. So that's the way these guys are treated just now and the way they live. To escape that, overdose is a key way out. Okay, really important. The sub-themes there, deep-rooted neglect, structural inequality. They're trapped in a toxic environment, they can't sleep, you can't get away from drugs when you stay in hotels, 150 people in them, everybody in together, you can't avoid it, boom, right in your face, every morning. You're getting offered something, and the grief of losing children, you know, so bereavement, counselling looms large. What's that, sorry? Aye, you get it there, you do, aye, you could go into the chemist or anywhere else. And discrimination still exists. So these are the things that people told us were the reasons for their overdose when you distill it all down. In terms of what prevents overdose, supportive relationships, going back to Adam's stuff and everybody else's today, I think. You know, stability. Right? Somebody to be in your corner and fight for you and be with you through thick and thin. If you're not believing that, I'll go on to another study that was conducted. It was a systematic review of the evidence. Folk are nodding, maybe some of the authors in the audience just now. Excellent study. Systematic reviews, when you look at all the evidence worldwide, published and unpublished, and you go through it with a tooth comb to find out what's happening. And this systematic review examined the views of people experiencing homelessness who had a problem drug, and tried to find out, you know, what does good look like for them in terms of problem drug treatment. And they also did another thing called meta-ethnography, which is quite complicated sounding, but it's quite easy. They looked at the findings that people said in the study, and they looked at the author's conclusions, so the patient's stuff plus the author's stuff, and they mashed it all together, and they came up with a new framework from all these 21 studies that were conducted in America, Canada and the UK, to give you an idea of what actually was being said. And what's been said, interestingly, didn't really talk about what, it talked about how. Okay, how care is received, how care is delivered, how care is offered. Again, it's not what you do, it's the way you do it, and I'm not going to burst into song because I'm not a very good singer. But this is about where you receive care. And all of you have had experience working with the patients we're talking about, and I'm sure you'll think of places where you'd like to receive care if you're in that boat, and places where you wouldn't. I'm not going to talk about the places where you wouldn't want to receive care, because I have a long list. The places that you would want to receive it, for example, for me, are the Simon Community Hub, just down the road there, where it's got all of these things down to a T. Okay, and the staff to receive care from is key, because of the stuff we've heard around relationality. You've got to get it right when you're offering people things. You've got to look at folk the right way. In other words, you've got to be sincere and want to help them. So a lot about, you know, relearning life skills because you haven't been taught them or haven't picked them up at all when you're younger. You know, we were encouraged to understand the complexity of people's lives. And the last bit there, powerlessness is re-traumatising. So you get that so many times when you approach services, and it has a massive impact. So all these are important. But again, the reason why I'm telling you, because we've tried to use this learning and then put it into a service that approaches things differently, rather than redescribing it again and again through different studies. The authors also picked up that stability was important. That was missed by the authors of the 21 studies. And so the authors here, Carver, Myler, Ring and Tessa Parks, they talked about stability being something that was overlooked but really important. And also the Alliance outcome relationship. I'm no psychotherapist, Adam, as you probably know, but I know that probably the most robust and effective predictor of a therapeutic relationship or an outcome from any kind of intervention is the strength of that relationship. So that was mentioned quite a lot as well. So finally, wee bit more qualitative stuff for you. So again, patients and patients' families and GPs and other healthcare workers were interviewed by O'Gorman Whittaker as part of the Drug Deaths Task Force funded stuff just not so long ago. And this was asking the question of, you know, what does get it right look like in terms of, you know, problem drug treatment and prevention of overdoses from the perspective of primary care folks. And this is what they found. It's more of the same, apart from the format has gone a wee bit. You know, so needs-led is important. So when thinking about any service, needs-led says it all for me. I think we're talking about people who've got multiple problems: health, social care, housing, everything else. And if you don't ask people what's important to them to begin with, then why are we even trying to offer help? We might think it's Hep C or HIV or problem drug use that's most important, but I don't think we should make that assumption. I think we should go to them, David, the way we do, and say, right, what is it you need help with today, and take it for there. Getting it wrong, you know, talks about fragmentation, and just as an aside, I'm still disappointed, I think, by services that don't share records. In some places you get, you know, 4 or 5 different sets of records for the same patient, all in the same building, and the records aren't shared. So that there's different approaches to this that I think we can get right quickly. In summary, for all of the qualitative work there, and apologies for the second bullet, there's too many words there, too many word salads, but I mean, I think Andrea, she's left now, but she talks a lot about unconditionality, and that's definitely the support that Andrea provides and her colleagues as a GP. We need to talk about, you know, relationality first and flexibility. With those two things in place, you can stick to people and you can provide long-term support. To recognise where those words come from, the second bullet, lifted straight out of Sarah Johnson's report on Housing First. So it's all the same. You know, if you offer people housing first, high fidelity, if you want it to work, you need that type of approach. Wraparound health and social care is lifted straight out of the NICE guidelines. Okay, I'm just distilling it all, and time to listen. So it's all right us setting up a new service when we've got a wee bit of time, but you know, you need to realise that staff just now are absolutely rattled with not having enough people in place, and so you can't just reinvent a service right now. You need more funding. You need more funding and a different approach. So going on to the characteristics of the people that we see within the Phoenix team, we've ran a study, and I'll go over that in a wee minute, time permitting. So characteristics of people experience. So the demographics, that's it. So these two things here actually match pretty much exactly with the characteristics of people who have died of an overdose in Scotland. If you look at the figures, okay, 42 years old, 71% male, nearly a quarter of a century homeless. What are we not doing, you know, or what are we doing to these guys that you can be that length of time homeless in Scotland? Doesn't make sense. The accommodations there, people generally feel very unsafe. There's a pervasive feeling of anxiety and depression. This isn't minor. PHQ-4 is a way of measuring these things. This is maximal levels of both. Okay, maximal levels of both. People were interviewed by a researcher, and it took 40 or 50 minutes per interview to get this information. And most people, Andrea mentioned it, the study we did a few years ago talked about people being, on average, looking like people and feeling like people who are 85 years old. Drug use of that population, so 128 people who are homeless and who'd recently overdosed. There's the drug use patterns. I've distilled this down, there's a lot more information. Most had about 3 overdoses. Polysubstance use, about half having used street Valium as part of that overdose. Most possessed naloxone and knew how to use it, but obviously it stops you overdosing in terms of dying, but it doesn't do anything to prevent the feelings and the need to overdose in the first place. I think we need interventions further upstream rather than downstream. I'm not saying we don't need the downstream, we absolutely do, but we need to move further upstream to look at the causes and try and address that. Lots of other things there about heroin and cocaine I think you probably know. Decomorbidity is the people that we see, they've at least got 10 different conditions, and who again are we to say this is the most important one and we're only going to manage your mental health today or your, you know, anything else. So I think the point of this slide is that of those people who've got mental health problems, and that's the vast majority, and these aren't trivial mental health problems, the vast majority are not anywhere near treatment. Okay, in terms of being engaged with a mental health service, and that's because it's really hard to get engaged with a mental health service, I would suggest, and because the mental health service is stretched, overstretched. So there's lots of things there, and there's about half of the folk actually in treatment. Where would you go if you had those kind of problems? Well, you'd probably first go to a hospital or a GP if available. But the problem is that GPs are very difficult to get hold of these days for us, and you probably just go to a hospital, and that's borne out in the figures that we have. In terms of over the last 6 months, there were no contacts with a GP for each patient on average, whereas there was a lot of contacts with the emergency department, because again, unconditional, you go there, you get seen, it's a warm environment, you don't tend to be judged because everybody's struggling, everybody's in the same boat. Okay. Radical response, I don't know, I'm talking about the service that we offer, self, George, David, and the team. The NHS plus third sector, it seems to work, that's what we do. We're non-judgmental, we're not perfect, and you could do a lot more with more resources, but we try to do as much as we possibly can. We did the service, we started it off for maybe 2 years or so, and then we thought we'd ask patients what they thought of it before we did any more work, and that's what we found. So we had qualitative research run by Sarah Johnson, Fiona Cuthull and Alison Blenkinsop, and that's what they told us, that's what patients told us the service did. Which was good, which was heartening, because if people come back to say, it's a load of mince and you're rude to us, then to be honest, I would have just gone on away and done something else. But this was the rationale for us then running a randomised controlled trial, the results of which will be available in about 6 weeks, where we've looked at patients who've received the service and those who haven't. And we've evaluated things like quality of life, overdoses, medicines prescribed, and all the rest of it. And that was funded by the Drug Death Task Force. And I'm happy to share that with you at another time. Okay. So thanks very much.